Um, this is sort of a refresher for our PIs and coordinator and a level setting for those who attending the community conference last month. We had shared a lot of the data and opportunities and recognitions for loss of sight. Our goal today is to revisit some of the high points about patient identification and recruitment, along with some responsibilities, and share some of the best practices from a couple of the sites, how they have been able to manage and fast track performance and recruitment at their sites. So Josh, can you go to the next slide, please? Thank you. So a little bit about activation recruitment updates, and then a revisit on activation, responsibilities, identification, recruitment and data submission, and spend a little bit of time about staffing turnover, which I know a number of sites have had to struggle with as they have sort of ramped up and started looking at recruitment and enrollment. Next slide, please. So currently, 40 sites have been selected and activated, with the last site being activated almost a month ago. So far, as you guys have heard at the community conference and subsequently, that we have 188 patients randomized, with at least 2/3 of the sites recruiting one patient, but there are still 9 sites that, despite being activated, have not recruited a patient. Cincinnati and CHKD, that's Children's Hospital of King's Daughter in Norfolk, are batting above average on this and leading the pack with 15 patients randomized at each site. Next slide, please. This is a very familiar graph that you guys have seen, and I will let Julie talk a little bit about this. Just sort of a housekeeping thing, we will be tag teaming for this call. So you will see Julie, Kim participate and join in sharing some of the learnings with you all. Julie, all yours.
All right, thank you. Can everybody hear me okay?
Yep.
So as Shahzad mentioned, CCHMC and CHKD are our leaders with 15 patients randomized at their sites as of our most recent data from the end of September. So this comes in on a regular basis, and this is the chart that we update to, again, monitor our total number of patients, which right now is at 188. So we are a little bit behind according to our recruitment goal that we had set for this point in October when we started this study. But you can see that we've got some great opportunities to kind of build from, finding what works well for CCHMC and CHKD, as well as those centers that are kind of to the left on the chart that have had success in going through each one of the process steps, from introducing research to patients, as well as covering the approach for this specific consent or for this study, as well as consenting and getting them into the study. All the way down to, again, Nicholas, who has joined us recently, and again, prompting the opportunity for us to develop some Spanish-speaking documents. So we're really excited to see this spread across so many centers, although we do recognize that we do have the opportunity to improve from this. On the next slide, if you want to go ahead and jump to that, this is kind of all study center results. And so when we think about how many patients are eligible for this, what we have found is that about 60% of your patients end up being eligible to be approached to move forward after you've done the pre-screening. From that then, out of those that are eligible, 80% are approached. So we really do a great job of identifying those patients and approaching them if they are eligible. Again, this is across all the centers, so we do have some variation in these that we can learn from. And then ultimately, once they've been approached, roughly 33% of those patients end up being consented. And so when we think about this, we really do want to understand what works well, what makes patients move forward, what were your talking points that were successful to introduce these different various points and kind of entry into the study with the families. as well as, kind of what happens that they don't get consented. Where are things not going as we intended them to do? And so we do generate a dashboard, and we're going to show that next. We recognize that it is a small font on this chart, and so we encourage when we send the slides out that everybody kind of takes a look at their centers. But on this is kind of representing the full study with centers listed over on the left, the date that you were activated in the study, and then various elements, again, kind of plotting that progress. And so we encourage everyone to kind of take a look at this and say, do these numbers really represent what you think your center's performance can be or is currently? We recognize that there have been some challenges along the way with staff turnover. And so if your center does have turnover, either in the PI or the coordinator or someone else impacted by the study, we do want to know that because we are monitoring from those weekly submission logs each one of these process elements. And so again, the number of pre-screened, so like how does this correspond to those patients that you have starting on an anti-TNF? The number that are eligible then, and then as you trickle through each one of these steps, how many are approached, how many are consented, and how many randomized? And so again, we have a lot of opportunities when we look at this data to say, is this what you think it should look like? If you have new staff, how can we help you out? If you have seasoned staff, how can we take your lessons and success stories and share them with others? So we encourage everyone to take a look at these, specifically the number of eligible, the percent that were approached, and the percent that are consented as kind of next steps to think about opportunities for your center.
Julie, I will also share one thing that, there's a column here on this dashboard which talks about consented patients per month per site and also randomized patients per month for site specific. And again, I would encourage people to look at these columns as well, because you can see where your own center is lining up here, and some of the sites that have really recruited amazingly well are almost approaching 1 patient or 0.8 patients randomized per month, which is a great metric to sort of compare yourself to and see where you're sort of lining up on that. Sorry, Julie, all yours.
No, that's great. Great addition to add. And so again, we do want to give the opportunity for centers to kind of weigh in on this. So if you have questions as you're going through or would like to comment on your center's performance, please jump in and let us know. But we do want to make this session a little bit more interactive. And so I just want to pause for a minute and see if there's anyone that wants to kind of comment on this dashboard. I believe everyone is unmuted. The other way you can comment is also to type in a question, and so we can monitor those as well and just kind of follow up as the session continues today. Okay, I'm not hearing anything, so we'll on the next slide, we've outlined the process map. And so again, in the spirit of quality improvement, we kind of want to outline the steps that it takes to get things accomplished. And so with this study, we've got opportunities along the way. And so really starting out with those centers that have been activated, completing their contracting and their IRB approvals. There were 6 that were activated in 2018. And so really understanding kind of what it takes to ramp you up successfully and where we can go with kind of supporting you in those early stages is an opportunity we're looking at. Next, we have obviously the steps to identify your eligible patients and approach patients, and then also activate those patients. And so all the way through, once they're recruited into the study, making sure that, again, the center follows the patients for a period of 2 years. And so that's where we move into more of a monitoring phase, and you get additional updates on these calls for different operational things along that line. And so that's all I'm going to share. We're going to jump to activation next, and so I'm going to hand it back to Shahzad.
Thank you, Julie. And again, I think this is a great sort of a process flow. So there are things that are happening on each step that you can think about what's your site looking like on those steps, and where are the opportunities that you can ramp up. Once a site is activated, you all get a welcome email from me, which sort of has some resources attached to that. It's a formatted email that you can send to your colleagues and their other staff members. There are FAQs. There is also a progress tracking form, and we have really found that progress tracking form to be very, very helpful here at Dayton. And it forces us to actually meet on a regular basis as a research team and review the patients that are are participating in the study. So I would encourage strongly for sites to utilize that tool, and also to meet as a group on a regular basis, weekly to every other weekly, because sites that have done that tend to be the ones that are really hardwired into identifying and approaching and recruiting patients in a very consistent way. We also have some resources after onboarding for coordinators and sharing best practices that is shared as part of the activation process. And then we have our QI support team as well as an engagement support team that meets on a regular basis, almost weekly, if not every other week for sure, to look at some of the stuff that you are involved in. And we will share later on the data submitting pre-screening logs submissions, and where there are opportunities to hardwire that and improve that process. Next slide, please. The next slide is focusing on the importance of data submission, because that's a foundational step. If we miss out on that data submission, then the rest flow does not work. And as you saw, that all those steps are connected and aligned with each other. So it's critically important that the sites look at data submission importantly and think of this as a essential step. We will reach out if we feel that the data submission is not consistent. And if you are having a hiatus for any reason, the coordinator is going to be out, there's vacation, PI is going to be out, whatever, please do let us know so that we can sort of keep that in mind and not count you as delinquent from that perspective if there is a good enough reason to do that. And this will be very important in completing the study and following these patients up through 2 years after the study recruitment time is gone. Next slide, please. And then I will hand it over to Kim Shelley from Riley, who's a coordinator extraordinaire.
Thanks, Shahzad. This is a study flow diagram that was started with when the study was put together, going through basically each of the steps. We've got pre-screening. You're looking for who is going on an anti-TNF, who has Crohn's disease, age. Those people go on your log. Then from there, you've identified who is eligible for recruitment, and you go through your recruitment and your consenting process. And then we have that follow-up. It is a 2-year study. It is a marathon. We want to make sure and maintain that relationship. We want to have the data, and we want to work with them. And also realize that in the follow-up, we have options. They're able to follow up while they're on drug or study drug, and then they can also be off of study drug if something were to change, and yet we still they're consented to follow. So just keep in mind that we have options as far as that goes. But it's a marathon. It's definitely a study that's a marathon. Next slide, please. So identifying patients. Some of the things in working with the various centers as we've onboarded the 42 sites, we've learned some best practices. They include trying to identify your patients at pre-visit planning meetings or population meetings. Really, one of the best places we found is when you're looking for working with the people that are doing the prior authorizations, the people who are responsible for that. And at that time, you're able to give yourself the most opportunity and the most time to be able to plan the various touch points with that patient. Time is important with this, since you have to have them enrolled before induction is completed. You can also track high potential patients. If somebody's coming in a flare and they may, look like they're going to an anti-TNF, or if they're having procedures scheduled, you can kind of put them on your watch list and see if they become eligible. We also find a lot of patients as we're reviewing the infusion calendars, since we have different locations for infusions. And we also have difficulty finding the Humira kiddos, and we find that when their teaching is scheduled, that's another great opportunity to find those kiddos. But the best strategy of all is communication, and there's so many different forms of communication. You can put a flyer up in clinic, you can do quick reminders at all the section meetings, just a couple sentences. The provider emails or some of the sources that Shehzad sends out with activation, working and communicating with your nurses is key. Do we have Amy on the call? Is she able to talk about how communication has been so successful for them at CHKD?
Not sure.
I do see her on the call, and I will unmute her just in a moment.
Awesome.
Okay, Amy, you're unmuted.
I'm here.
And next slide, Josh. That's Amy's slide.
Hi, everybody. So I will keep this short. Just wanted to share a couple of quick things that have helped us to be really successful. One is that we constantly talk to each other. It's easier for us because we're a smaller group, 6 physician nurse teams. The pre-auth process is really helpful. The nurses that take care of that always try to keep me in the loop. I shared with the group on the Tuesday call that I actually don't work in the practice. So it's really important for them to stay in communication with me about these patients, because I am not in the loop, so to speak, on a lot of what's going on with patients. So we meet twice a month and we talk about potential patients there. So it's just really, it's become ingrained in us as we're also doing produce. So we're always looking at potential patients. And then the other thing that has, I think, been just what's really put us over the top is that I am never the first person to meet the family to talk about this. For instance, I went to see a family yesterday. It was their first Remicade visit, and they already knew so much. I was really impressed. I went and patted my doc on the back and said, "Good job." It makes my job so much easier. But the other key to that is that it was the first infusion, and it was a 15-year-old boy who seemed a little timid. I think he was nervous about his infusion. And so I was able to say to them, "Here's the poster, here's the consent, go home, talk about it. We have 45 days. I will see you in 2 weeks when you're here for your next infusion." So, and that is if you're able to, I realize not all centers are, but if you're able to capitalize on that infusion period where they're available for an extended amount of time, because time is always an issue. We do most of our combined work at the infusion visits, which has been really helpful as well. So that's my short elevator speech.
Thank you, Amy. This is a perfect elevator speech. It's been working, as you can see. So we are really greatly thankful for all your efforts and sharing your best practices with the rest of the group. Next slide, please. So this is again an overview of what the flow of study is. As Kim shared and Amy also shared, the pre-visit planning meetings, the population management meetings, PA, chart review are all great entry points for patient identification. For centers and programs that have fellows, touching base with the fellows is a critically important step, because they may have their ear to the ground much more than a lot of the other folks. And especially on the inpatient side, they know who's getting scoped and who's getting flared up and who may be going to the PATH conference for reads and all that stuff. So engage with them as important. Amy alluded to this as the warm handoff, that she's never the first person to contact the patient or the family. So once the patient is identified, reach out to the primary GI provider is critically important, and that GI provider's relationship with the patient will serve as a great niche and a decider for the family to think about participating in the study. This could be done either through clinic at infusion clinic as an outpatient visit, and or infusion center as Amy shared, and then by email and phone. And then the research coordinator can do the rest of the communication, sharing of the protocol, discussion with the PI, being available as a resource and answering questions. They will either decide to participate and get enrolled or not, and then we are also capturing the reasons why they decide not to participate in a separate focus area. Once they are enrolled, then I think the next step from our perspective is the support that we can provide to you guys, and focusing on retention for the next 2 years, and providing support through monthly calls like these, and newsletter, which is shared every other week, and sharing of the metrics with the group. Next slide, please. Kim, all yours.
All right, so with recruitment, you know, as you've talked about that, the data submission is so important. We've learned so much, made changes to how we do things in the study because of that information. The provider introduction and handoff is key, as Amy shared with us. It's so nice and refreshing to be able to go in there and have a patient that is well educated on the study, may have a handful of questions, even if it's just introduced so that we're not the first person going in introducing the study. It makes things much easier and more patients and families more willing to have that research conversation with us. And then there are so many resources available that are IRB approved and that we can use in our recruitment efforts. We've got the FAQs. Instead of sending home a consent that's rather daunting, you can send home the FAQs. You can direct them to the trial website. There's an amazing video that has been developed that's really very underutilized, but the people who do watch it and the families and the kids who do watch it have positive feedback from it. So maybe try to consider incorporating that into your recruitment process. The engagement team and the study team is here to help. We're able to help coach you through whatever it is that you need. We're all approachable. We're all here to help. And we've also developed an SOP for phone consenting, especially if satellites are sometimes an issue, or if there's Saturday infusions and things like that, we can work to consent them over the phone. Lots of options to have successful recruiting. Next slide. And somebody who has been successful with recruiting is Nebraska. And I think Shahzad, they're not able to join us. Were you going to take this one?
I can definitely take this one. Thanks, Kim. Nebraska is a great example of fairly recent ramp up, and they have been able to randomize 5 patients in the last 4 months with a consent rate of 63, which is an amazing consent rate. And what Mark shared, Dr. Cusack shared with us on Tuesday's call was that that they have a couple of good touch points. They have 2 nurses that do most, if not all, of their pre-authorizations for biologics, and they have frequent touch points and check-ins with those nurses, and they are then in touch with the coordinator to let them know who's coming in, who's coming, and where they are. Also, the research coordinator emails these nurses on a weekly basis to check on them. So again, if you have a process where pre-authorizations are handled by a limited number of people, that's a great touch point to sort of keep in mind. As we have heard from Amy, from Kim, the warm handoffs are amazingly important and critical. And it's all the relationship that the primary provider has with their patients that can set this up appropriately. It's important to share this with the rest of the group, and it is important to set the coordinator up appropriately so that the coordinator can take it on from there. The PI, Dr. Cusack, shared that he's around when this discussion is going on with the coordinator to answer any questions, concerns that the family may have, especially about combination therapy concerns and information like that. So it's great to have that kind of a backup in the clinic readily available. Next slide, please. The next slide actually is a sharing slide, which is to bring this back to our situational awareness and radar screen that we have noticed in the last 6 weeks to 8 weeks almost that the submission of data by sites to the central group has tapered off. And we thought that may have been to do with DDW and then ICN and vacation, summertime, and then ICN community conference. But we want to bring this back to people's attention that we would love to see this get ramped up back up to the median point of 74-75%. We have really tapered off on this. So we will be reaching out to the sites that have not submitted for a several weeks timeline. Next slide, please. This is a foundational step, and it is critically important. I also wanted to share another sort of critical piece, which relates to approaching and identification of patients. Since last 6 months or so, since early February, 12 out of the 40 sites that, 38 sites at that time that had been activated, 12 of these sites had coordinator turnout. And since that time, we've had 3 sites which have had PI turnover as well. So plea to the sites, if you are going through any of these transition periods, please do let us know so that we can keep that in mind and don't bug you too much if there is issues that are cropping up. We will give you credit for this transition. Next slide. I will not go the next slide. It is basically who's who in Combine, and this is shared with all sites at the time of activation. There have been some staff transitions as well, so some of those are updated over here. And everyone knows that Mike Kappelman is available day in and day out, except when he's on vacation. So please do reach out, and we have a system where if he's not available, there are other people who can be reached if there are burning questions about the study. I will take a pause. We've got a couple of minutes left over to see if there are questions. One thing that has come up since the Tuesday call was utilizing resource parents. So the study has leveraged parents whose kids are either participating in the trial or who have knowledge about the research question, and we want them made available as a resource to sites for talking to parents who are struggling and are having questions and would love to hear from a peer. So I would be really interested to see if any of the sites have utilized that resource by now. This is an opportunity for people to share their experiences. If you're not able to call in, please raise your hand. I hear silence. That's a signal that I think people are good with this. As always, please do reach out. Next slide, please. I think that's the end. Thank you. So thank you for taking the time in the middle of the busy day to join us on the call. This call has been recorded, so if you have questions, please do reach out to us. We will send the slide deck back to everyone later this week. Before I sign off, any other thing to add, Julie, Kim?
I don't have anything to add, but thanks, Shahzad. This was good.
Great. I don't know if Mike's on the call or not, but if he is, feel free to share. Sounds like that everybody's Done. Thank you so much for joining. You all have a great rest of the day.
Thank you, everyone.